Welcome to the lecture, Fluid Homeostasis and Fluid Dynamics. In this lecture, we're going to talk about the fluid compartments and how fluid moves between those compartments and some of the forces that affect that. We'll talk about the primary hormones that influence fluid homeostasis, both physiologically and how that can become pathophysiologic, as we'll be dealing with that later in the semester. And then we'll also talk about how age, as well as body composition, can actually affect our fluid balance and our total body water. So let's talk then first about total body water. I know this is review, but I think it's important that we all be on the same page when we talk about body water. So in the average male, remember that's our reference for many of the things we know about physiology, an average male has 60% of their body weight in water. So that's what we mean by total body water. So 60% of an average male, 60% of their weight is body water. As you can see, the vast majority of that is intracellular, about 2/3 of it, and then the rest of it is extracellular. And that extracellular fluid is distributed between the interstitium and the intravascular space, which is that extracellular space. And it's about a 4-to-1 ratio of interstitium to intravascular. So it's important then that we think, though, about other patient populations other than the average male. Sorry, guys. So first off, gender. Women are about 50% total body water. So 50% of their body weight is water, as opposed to the 60% in the male. As we get older, we gradually have less of our body weight is water. So when we're born, infants are about 70% water. So 70% of their weight is fluid. So this is important then when we think about shock states. It makes sense then why hypovolemic shock is the most common shock in an infant. It also then helps us understand why fluid requirements are very high in an infant as it relates to their body weight. But as we get older, our total body water percent begins to decrease, so that by the time we are elderly, and when we're talking about elderly, this starts in the 60s and on into the 70s. So our frail elders in their 80s and 90s may only be about 40% total body water. Again, that becomes very important in hypervolemic states, because if you give too much fluid to an elder, you can make them hypervolemic and have negative cardiac effects. So we use this understanding all the time in understanding not only our physiology, but our pathophysiology. For patients who are obese, we need to remember that fat has less water, holds less water than muscle. So fat cells have less water than muscle cells do. So as a result, when you have a patient who is obese, remember that their total body water may be anywhere from 40 to 50%, as opposed to that normal that we talked about for a female or for the male. So these are important concepts to remember. The other piece we want to remember at all times when we're thinking about body water is that fluid is constantly moving between the compartments. So there's a constant movement of fluid between the intracellular and the two extracellular spaces. And that fluid is constantly moving through aquaporins in that lipid bilayer of the cell, and it primarily moves by diffusion. So let's take a look at how this kind of plays out. Just kind of to summarize what we talked about. So in the reference 70 kilogram male, we know that about 60% of that reference male their weight is water. So that 60% of 70 would be 72 liters. I love English spelling. So then when you separate that out into the extracellular and the intracellular volume, you can see the difference there. Then further separate out the extracellular fluid volume primarily to the interstitial as well as the intravascular or the plasma space. So you can see that very little of our water is actually in our circulatory space, in our plasma or our intravascular space. Now there's also a little bit, and you can see half a liter, that's not a whole lot, that's 500 cc's. So there's a little bit of, they call this transcellular fluid, and this is some fluid that's moving around again, but remember that's in the extracellular space. What about hormone activity? There are three primary hormones that we think about a lot when we think about fluid and fluid balance. And those include antidiuretic hormone, or ADH, aldosterone, and natriuretic hormone. I've listed it here as atrial natriuretic hormone, but more broadly, we really should think about that as natriuretic hormone, because even though it was first identified coming from a site in the right atrium, we also know that there are brain types, and there's also some hormone that comes from the carotid sinus. So let's talk about these hormones a little bit. Antidiuretic hormone, or ADH, is when you stimulate that, you decrease the excretion of water by the kidneys. So ADH works on water to decrease the excretion of the water. So antidiuretic hormone means you're going to hold on to water. ADH, remember, comes from the posterior pituitary. The other thing that we know about ADH is that it attaches to receptors, and there are V1 and V2 receptors. The V1 receptors are in vascular smooth muscle as well as the anterior pituitary. The V2 receptors are the receptors that are in the kidney collecting ducts. And so because they're in the kidneys, which is where you see a lot of the activity of this hormone, it mediates antidiuresis. Thus, the end result is to increase the activity of the aquaporins to bring back water. Aldosterone is a mineralocorticoid, and as a result, the mineralocorticoids are released by the adrenal cortex. Now this all starts in the anterior pituitary with adrenocorticotropic hormone, ACTH, which then goes to the adrenal gland itself, and then the adrenal gland produces the mineralocorticoids. So it stimulates the adrenal to produce aldosterone. When we stimulate aldosterone, this stimulates the kidneys to reabsorb sodium. And the primary site of this is going to be in the distal convoluted tubule and in the collecting ducts. So this is an important thing to remember. Aldosterone works to reabsorb sodium. And remember, ADH, you decrease the excretion of water. So ADH works on water, aldosterone works on sodium. Now, it's important then, though, to remember in our normal physiology that water's stupid. Water follows sodium, which is why aldosterone, because of its reabsorption of sodium, affects our fluid balance in such a very, very powerful way. The other stimulus for aldosterone, the other important piece to remember about aldosterone is that it's part of the renin, angiotensin, aldosterone mechanism. And remember that RAS, the renin, angiotensin, aldosterone mechanism, is a very important part of our stress response. Anytime the kidneys believe that they are not being circulated, which happens in stress or in hypovolemic states, the kidneys are stimulated to produce renin, or renin, depending on where you went to school. So renin is produced by the juxtaglomerular cells in the loop of Henle, and so it's very early in the mechanism. Renin stimulates the production of angiotensin 1. Angiotensin 1 converts to angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor. So in the stress response, that makes sense because you want those vessels to clamp down because you've got to circulate the priority organs. But the other thing that angiotensin 2 does is stimulates the release of aldosterone. Because remember, when you're running from a bear, you have to have a positive fluid balance. So not only do you need your vessels to clamp down under the influence of angiotensin II, you also need the kidneys to reabsorb sodium so that you reabsorb and reclaim all the water you can to keep your blood volume up so that you have enough blood pressure to circulate your muscles to run from the bear. So I hope that made sense. I like running from bears. I think that's fun. You can also see that as running from your faculty, although since you're in the online course, I'm guessing you're not going to feel a big need to run from me. The third hormone is the natriuretic hormone. The natriuretic hormone, there are actually 3 places where this hormone is secreted. By sites in the atria, the carotid sinus, as well as in the brain. And these receptors for this hormone are very sensitive to stretch. So think about stretch. When we've been talking about ADH and aldosterone, we've been thinking about volume contraction, needing to increase our vascular volume. With ANP, or atrionatric hormone, or natriuretic peptide, these receptors, because they are sensitive to stretch, block ADH and block aldosterone. So the net effect then is under the influence of the natriuretic hormone is to excrete sodium and water. Because where these hormones work, where these natriuretic hormones work, is within the kidneys. They increase the afferent and decrease the efferent arterial pressure so that you perfuse the glomerulus better. When you perfuse that glomerulus better, the kidney's saying, oh, I've got enough fluid. I don't need to keep holding on to sodium. I don't need to keep holding on to water. But remember, this all started with those receptors in the carotid sinus, the brain, and the atria that were sensitive to stretch, to block the effects of ADH as well as aldosterone. So the last piece that I put on here, it's not a hormone, but it is an important mechanism, and that's the thirst mechanism. The thirst mechanism is situated very close to the posterior pituitary, so it's right around that hypothalamic area. And remember from your normal physiology that the hypothalamus has a lot of osmolality receptors. When our total body water decreases by about 2%, these osmolality receptors are stimulated. They're very, very sensitive. But what this thirst, and in this thirst mechanism that is receptive, that regulates our conscious desire for water to drink so that we then respond to this decrease in the total body water. And remember, 2% isn't very much, but it's one of those compensatory mechanisms that physiologically tells our cognitive system, get something to drink. You need some fluid to do that. But think about response to that. Which of our populations may have difficulty responding to that stimulus? This is the part where you shout at the screen or shout while you're listening. Yes, you're right. Children and elders. So a child may not have the cognitive ability to know or be old enough to gain access to water. For an elder, their osmolality receptors aren't quite as efficient, or they may also have difficulty accessing water because of either some cognitive defects or because of mobility defects, and they can't get to that. So when we think then about hormone activity, when we think about antidiuretic hormone, antidiuresis, the idea there is when we stimulate that, we will decrease the excretion of water by the kidneys. So when we need to hold on to water, it would be because our plasma is very concentrated. With aldosterone, the kidneys are stimulated to reabsorb sodium and therefore water, because remember, water's stupid. And so it's going to be released in response to a hypovolemic state, a hyponatremic state, too much potassium, and of course we talked about running from your faculty. Oh, I'm sorry, the bear. And then natriuretic hormone. Natriuretic hormone counteracts or blocks the response to ADH and aldosterone because the natriuretic hormone is stimulated by stretch. And because it's stimulated by stretch, which would be because there's a lot of volume in the system, it's going to turn off the antidiuretic hormone. It's going to turn off the aldosterone so that you bring that volume down to a isoosmolar or a normal volume state. So where do those hormones work? I think we've talked about a couple of them, but because remember, most of this is happening in the kidneys. Oh, I like kidneys, and so I know by the end of this course, you will too. So hormone activity, the sites of action. In the proximal tubule, which is that first part of the kidneys, there isn't a lot of hormone activity. A little bit to aldosterone, but not a lot. Because most of the sodium that we reabsorb in the proximal tubule is down a concentration gradient. In the descending loop of Henle, again, very little hormone activity because the descending loop of Henle is already physiologically permeable to water, but not a lot of sodium. In the ascending loop of Henle, again, not a lot of hormone activity, but physiologically in the ascending loop of Henle, the cells are more permeable both to sodium and chloride, but not so much to water. So you see in the balance now? In the distal tubule and the collecting duct, this is where the hormones take over. And this is where we also essentially fine-tune our fluid balance as well as then our sodium and potassium balance. Now, when we think about fluid dynamics and fluid homeostasis, the concept of serum osmolality is an incredibly important concept, and this is something I really expect you to have a good understanding of because it really helps us understand things. Serum osmolality measures the solutes in the plasma. So a normal, and so because you're measuring solutes, you're measuring essentially a concentration. So a normal serum osmolality is 275 to 295 milliosmoles per liter. I don't expect you to know labs, but I do expect you to develop an understanding of what contributes and how it's affected and what it means. So then, as that number goes higher, above 300, that increased osmolality means that the plasma is concentrated. As you get below 270, 260, right around, below that normal, that's a decreased osmolality, means that the plasma is more dilute. Now we can both calculate as well as measure the serum osmolality. And once again, I don't expect you to know this formula, but I do expect you to understand the components of the formula and what they mean and why they're important. Because these are physiologic concepts that pathophysiologically you can see as we talk about them. So in general, if someone is healthy, if you calculate their serum osmolality, you take their serum sodium level, multiply it by 2, add 10, and you're going to be within the ballpark of what's measured. Now, why does sodium work? Remember, this is where you shout at the screen. Yeah, because sodium is our primary extracellular cation. And so as a result, it has a primary effect on the extracellular osmolality. So if I take 2 times my sodium level and add an unmeasured value of 10, because there's always some stuff out there we can't measure, you're going to be very close to what is in that measured osmolality on your lab work. So a normal serum sodium is about 135. So if I take 2 times 135, that's 270. I add my 10 for normality, and you can see that now I have a serum osmolality of 280. Stone cold normal. Great. However, we know that there are substances that can be in the plasma that, because they are large osmoles, can also affect the serum osmolality when they are elevated. Glucose and urea nitrogen are two great examples of that. So if someone is hyperglycemic, you can see that we can calculate that out. We can calculate the relative contribution of hyperglycemia. If someone is uremic and has an elevated blood urea nitrogen, we can also correct or calculate that out. Because if you, and as you add those things together then, because remember, what you're trying to do is figure out whether or not your calculated and your measured osmolality are close. If alcohol is present, so if you have someone who is intoxicated or has a very high alcohol level, you can also, because it's a big osmol, alcohol's a big osmol, you can also bring that into your calculation. So the important concept here is that there are things that we can measure on a fairly routine basis that are large osmoles and we know have an effect on our serum osmolality. In general, our measured osmolality should be slightly greater than our calculated osmolality. And this is because there are things in our plasma that we don't always have a way of measuring. But that calculation is a great estimation. Now, there is something called an osmol gap, and that is the difference between the calculated gap and the measured gap. So when you know what osmoles are there in your calculation, and you subtract that from the measured gap, if it's greater than 10, then there's other solutes there that you're not aware of. So maybe additional toxins, other substances. If the gap, the difference between measured and calculated is greater than 50, there are other solutes present, and because those other solutes are unknown, they frequently fatality. The other thing that's important about this osmolality is that, and this is the concept, and once again is the gap, is because that osmolality is affecting the movement of water. So sodium is responsible for our primarily responsible for our extracellular osmolality. What would be primarily responsible for our intracellular osmolality? Yeah, potassium, because that's our primary intracellular cation. So we know that osmolality is an important concept because our osmolality affects the movement of water in our fluid spaces. The osmolality of our extracellular fluid spaces help move fluid among and from compartments. So let's talk a little bit about some other things in fluid physiology, and that you can't get away from sodium, right? Because remember, water follows sodium, so we've got to know something about sodium. So certainly our serum sodium level is important. Always, though, look at a serum sodium level in relation to water, because remember, sodium is very active in that osmolality. So when our serum sodium is very high, I would be looking for a low volume state. When my serum sodium is low, one of the things I'm going to think about is, have I pulled a lot of fluid into that vascular space and it's diluted out? The value of the urine sodium is to determine whether or not the kidneys are trying to correct it. So and this is the fractional excretion, both the absolute level and the fractional excretion. So a fairly normal urine sodium level is about 20. So if it's less than 20 and the fractional excretion of sodium is less than 1%, then you know that the kidneys are working very hard to bring back that sodium because they're not excreting it. When the urine sodium is greater than 20 and that fractional excretion is greater than 1, then we know that the kidneys are letting the sodium out, or they're unable to correct our sodium level. In serum glucose, remember serum glucose we talked about having a big effect or a potentially large effect on our osmolality. So as a result then, when we look at a very high serum glucose, you'll see that the serum sodium level would be low because the serum glucose is an osmol. Serum osmolality became more concentrated, went up, and we pulled, as a result, more fluid came into the vascular space, therefore diluting that serum sodium level. Two other pieces in fluid physiology that can increase our osmolality and therefore affect fluid movement include serum protein and serum lipids. When either of those are significantly above physiologic levels, they increase the osmolality, and by increasing the serum osmolality, have an effect on the movement of fluid into the vascular space. So let's look also then at forces that move fluid. So we've got a good understanding of osmolality. So now let's look at forces. And the thing we want to remember when we look at forces that move fluid, we always want to remember that fluid moves across a semi-permeable membrane when we're talking about the interstitium and the capillary space. So we're talking a lot about our extracellular spaces. So we have to remember that fluid moves across a semi-permeable membrane, that in general there is free movement of sodium, water, and glucose. However, protein does not move freely. So those are important concepts. Semi-permeable membrane, free movement of water, sodium, and glucose, but not free movement of protein. Protein is a very large molecule, has very important physiologic effects on the movement of fluid. So we'll look at two forces and two spaces. The two forces we'll look at are hydrostatic pressure and oncotic pressure. The two spaces we'll look at are the vascular or the capillary space and the interstitium. So again, we're looking at that 1/3 of total body water that's in the extracellular space here. So let's look first at capillary hydrostatic pressure. With capillary hydrostatic pressure, water moves from the capillaries into the interstitium. So a way of thinking about that hydrostatic pressure is that water is being pushed from the capillaries into the interstitium. Capillary oncotic pressure is a pulling pressure. So in capillary oncotic pressure, water moves from the interstitium into the capillary. So it's the other way around. So capillary hydrostatic pressure is water moving from the capillaries to the tissue. Capillary oncotic pressure is movement of fluid from the tissue to the capillaries. So that's then look at that second space, the interstitial space. Interstitial space has the same pressures. So in interstitial hydrostatic pressure, water is moving from the interstitium into the capillaries. So it's pushing from the interstitium into the capillaries, from tissue to capillary. In the interstitial oncotic pressure, water is moving from the capillaries into the interstitium. So it's, again, you're pulling into the interstitium. So another way of looking at that then is oncotic pressure is an attractive or a pulling force. Hydrostatic pressure is not attractive. It's a pushing force. These are important pressures and important concepts. So hint, hint, have a good understanding of those. So how might what's another way of looking at that? So let's look at those net forces. So those net forces, these are the Starling forces. We're talking about the same thing, didn't change anything around here. So let's think about those net forces. So if you pull what we just talked about together, the net force of capillary hydrostatic and interstitial oncotic forces is to help move the fluid from the capillaries to the tissue. The net forces of capillary oncotic pressure and interstitial hydrostatic pressure is to help move fluid from the tissue to the capillaries. Got it? Great. So let's take a little bit and let's see if we can sort of apply this a little bit then. So let's look at some fluid and pathophysiologic concepts. And these are things that, once again, take some time with this. These are some of those concepts in a patho course that I want you to have a handle on because we'll use them throughout the semester. So the first thing is remember the fluid shifting. If you change one space, you change another. Fluid is constantly moving among our spaces, the interstitium, the vascular, and within the cells. So we're always moving things. But let's look at some pathophysiologic states that can affect the movement of fluid, and for a variety of reasons. Sometimes those things we've already talked about, but not completely. So let's look at malnutrition. With malnutrition, and shout at the screen as we go through this. So with malnutrition, what happens to our serum proteins, our serum albumin? Correct. It's decreased. So with that decrease in albumin and protein, which is a very big osmole, what happens to our oncotic pressure in the vascular space? Yes, it's decreased. So with a decrease in the albumin and protein level as a result of malnutrition, that decreases the oncotic pressure in the vascular space, and as a result, fluid is going to move into the interstitium. In sepsis, because of the septic process, there is an increase in capillary permeability. So as a result, you sort of have leaky capillaries. Because of the increase in capillary permeability, fluid is more likely to move from the vascular space into the interstitium. And you've probably seen this in your septic patients. So what about the influence of steroids? Well, steroids are mineralocorticoids. So as a result, and again, you've seen this in your practice. When you've had patients who are on chronic steroid therapy, they may have issues with hypernatremia and hypokalemia. Because steroids because it's a mineralocorticoid, increase the retention of sodium. Remember, water's stupid, it follows the sodium. Postoperatively, a normal physiologic response is to hold on to fluid. And if you think about, I don't know about you, but if I just went through surgery, my body would see that as a stress response. So postoperatively, I have initiated the stress response, and under the influence of the stress response, my physiology stimulates the renin, angiotensin, aldosterone mechanism. So once again, aldosterone, increasing the reabsorption of sodium and increasing the amount of fluid I hold on to. If you work with surgical patients, you have seen this physiology. First off, they get a lot of fluid during the surgical procedure, especially if it's a long surgical procedure, because we want to keep their pressures up. We want to keep their blood pressure up, right? But because of the stress response, we hold on to it for a while. So you'll see your patients initially post-op hold on to that fluid for a while, and then over the couple of days after surgery, their body starts letting go of that fluid because they start healing, the stress response lessens, and now they're going to get rid of that additional fluid. In pancreatitis, because this is an inflammatory process, there's an increase in capillary permeability. Yes, a manifestation of that increase in capillary permeability is the possibility in a pancreatitis of the development of a pleural effusion on the left side, which of course is where the pancreas is. And then now I'm going to turn things around on you and look at the mineralocorticoid deficiency. So if I don't have enough mineralocorticoids, I will not be able to I don't have aldosterone. Therefore, I can't retain sodium effectively, and I can't then respond to stress. Make sense? Great. All right. So that's how some of those pathophysiologic concepts play when we think about fluid shifting. Let's take a look then also at the pathophysiology then of edema, because we see so much edema. The first thing you want to remember about edema, though, is not only is it a fluid measure, it can also be a circulatory measure. But we're going to talk about it as a fluid measure. The other piece we want to remember about edema is we're looking at the distribution of fluid versus true volume. Because when you're looking at edema, you're looking at fluid that's in the interstitium. So what are those forces? Those forces, the hydrostatic pressure. Under the influence of hydrostatic pressure, we have more fluid has moved from the capillaries into the tissue. So this is someone who's volume overloaded. They've got a lot of hydrostatic pressure. But we also have to think about oncotic pressure. If there's no oncotic pressure within the vascular space, because you've lost albumin, fluid will move from the capillaries into the tissues, because that interstitial oncotic pressure is higher than what's in the capillaries. In edema, once again, we think about capillary permeability. Is there an inflammatory process that is increasing capillary permeability that then, again, fosters fluid moving into the interstitium? And then the fourth concept is lymphatic drainage. If lymphatic drainage is blocked because of disease or compression, you'll decrease the lymphatic drainage through those lymphatic drainage channels, and that blockage of lymphatic drainage can also increase the amount of tissue in the interstitium. So think about the pathophysiology of edema and think about it in terms of fluid spaces as well as the movement of those forces. The other thing that I think is important in here, and I didn't put it on the slide, but let's think about it for just a little bit, and that relates to fluid therapy. We give a lot of IV fluid, right? So as you hang that next bag of IV fluid, think about the tonicity or the osmolality of the IV fluid that you are hanging, that you are dropping into that vascular space, and how that osmolality of the fluid you are delivering is going to affect fluid shifting, because and I know that's therapy, but fluid shifting is so important that I think it's worth talking about. So think about normal saline. Normal saline is 0.9 sodium chloride. That is an isosmolar or an isotonic solution. So it's the same tonicity, osmolality as plasma. So then if you put something in normal saline, that becomes a hypertonic solution, hyperosmolar. Or if you take something out of it, it becomes hypotonic. So let's think about what would happen if I give a hypertonic solution. You give 3% or 4% sodium chloride. What's going to happen to fluid? Where's the fluid going to move? It's going to move from the interstitium into the vascular space. Now, when that happens then, because you've moved fluid from the interstitium into the vascular space, what's the cell going to do? It's going to give up fluid to the interstitial space, because remember, dynamic. A hypotonic solution, 0.4, we don't use a lot, but you can give quarter, which is 0.25, or a 0.45 sodium chloride. When you give a hypotonic fluid, what's the movement? Correct. The fluid is going to move from the vascular space into the interstitium, and then from the interstitium into the cell. So when you're thinking about giving fluid, or when fluid is being removed and replaced and moving between these compartments, it depends on the osmolality of the space relative to its adjoining space. Because remember, you're constantly moving fluid among your extracellular and your intracellular spaces. What then could be some of the sequelae of our fluid alterations in our physiology? What happens so what are our concerns with volume deficit and volume overload? Well, with volume deficit, our biggest concern is the decrease in perfusion. Because with decreased volume, you're going to have decreased circulation to the area. And both with volume deficit and volume overload, it's going to alter our cell-to-cell interactions, because physiologic substrates move through fluid. And our fluid constituents, as well as the amount of fluid, is going to affect those interactions. With volume overload, our physiologic sequelae and concern are going to relate to impaired oxygen and metabolic diffusion. You remember, we were worried about oxygen in deficit as well. We're going to worry about obstructed capillary flow and lymphatic drainage, because if you put too much pressure in the system, then the capillaries are either going to have pressure from the outside, or there's going to be so much pressure inside that they're not able to work effectively. What about organ function then? How will too much fluid affect the functioning of essential organs? In the cerebrum, in our central nervous system, probably the biggest thing to think about are cognitive effects. And you'll see this with your patients that are volume overloaded. In the myocardium, our concern is contractility. Initially, we can keep pumping that bigger load, but after a while it begins to fail. In the pulmonary system, we're concerned about gas exchange because of alveolar fluid. There's too much, if there's a lot of fluid in the alveolar spaces, we know that our gas exchange is going to be diminished. And then, of course, if there's a lot of fluid, our work of breathing goes up and we're fatiguing. With the kidneys, there can be a decrease in the blood flow and a decrease in the glomerular filtration rate because there's just so much fluid in the system. In the liver, when the liver becomes congested with fluid, the synthetic functions of the liver are diminished. In the gut, slows down our motility, and in our tissue, decreases circulation, making us more likely to undergo skin breakdown. So what do I expect you to know about this piece? Probably the important concepts here about the fluid alterations is to have an understanding of how, when we move fluid around and where the fluid is, how does that affect our perfusion? How does it affect our diffusion of substances? And how does it affect the overall health of those spaces in terms of both delivering oxygen and nutrients, as well as removing waste products through lymphatic drainage and other mechanisms. We've talked about a lot in the last 40-odd minutes. We've talked about the movement of fluid among and between compartments as a very dynamic and constant process. Some of those key concepts and ones that are very important for us to remember, and I think and I would make sure that you have a good handle on, are the pressures and the locations and how the fluid moves along that. That idea of serum osmolality, because you're going to use that concept over and over. And the hormones, The stimulus for hormones, how the hormones affect homeostasis, very important as we talk about pathology, so we'll form the basis now. And then as we identified, osmolality of fluid matters. It matters in normal physiology, it matters in pathophysiology, and it matters in our therapy. Thank you so much for your attention. If you have any questions, please let me know.